Hello everyone, Kent.Bressler here. I want to welcome you to Kent's Kidney Stories. During our time together over these podcasts, I'd like to discuss kidney disease. I'd like to tell you about my journey as a transplant patient, but also talk about dialysis, kidney donation, and just about anything else that might be of interest. Kent's Kidney Stories, a podcast endorsed and sponsored by kidneysolutions.org.
Hello, everyone. Kent.Bressler here with Kent's Kidney Stories. I'm going to podcast this morning. It's morning where I am with Dr. Rachel Davis, and we'll introduce her a little later. I wanted to start with prayer this morning, and so you might want to prepare yourself here. To our dear Lord and Holy Spirit, drive away from us all forms of sickness and disease. Restore strength to our bodies and joy to our spirit. So then, in our renewed health, we may bless and serve you now and forevermore. In your holy name, amen. Now, I've had this several patients in the past who have had issues with lithium, which is a very common drug in the medical industry and in care and therapy. But when I met Dr. Davis, it was quite interesting how this all played out. But I've read her research project more than once, and I gleaned some stuff. So I'm going to set the tone here for this conversation with her. So bear with me on this introduction. Roughly 90,000 people are on the waiting list for a kidney transplant, and 10,000 are removed from that kidney transplant waiting list each year, either due to becoming too ill or ill for a transplant or due to death. Live donor kidney transplant, or LDKT as we'll refer to it, provides superior outcomes and survival benefit relative to a deceased donor transplant. Well-known fact, but it's well worth repeating. But the number of LDKT has decreased over the past few years, and that's significant in my thought process. Everybody thinks it's gone up. It has not. It's actually decreased. Of 90,000 candidates listed for a kidney transplant in the U.S., a mere 25,549 received a transplant, and that was relatively since 2022. It is important that transplant centers employ evaluation process that safely maximizes LDKT. Decisions about donor candidacy should be based on the best available data rather than on processes prone to bias. This study examines the common practice of declining potential donors based solely on treatment with lithium and concludes that the risk of end-stage renal disease related to lithium treatment is comparable to other generally accepted risks in living donation. The benefits of lithium in the treatment of bipolar disorder have been known for greater than 60 years, and despite large efforts of pharmaceutical companies to develop alternatives, lithium is even today the most effective medication for this disease process. 76%, that's 76% of living donor programs considered an active mental health problem to be contraindicated for donation. So when I found out that Dr. Davis was going to do a research project, be part of a collaborative on this program, I wanted to get in touch with her, and she's really delightful. I've corresponded with her via email mostly and text, and we've talked on the phone, but very interesting character in my book, and I'm really looking forward to this. She's an associate professor of psychiatry and neurosurgery and the vice chair for clinical affairs and strategy and Chief CU, that's Colorado University Medicine, Psychiatry, Community Practices, Service Director, Psychiatric Neuromodulation, and Co-Director of the OCD Surgical Program, and the Medical Director of the OCD Program. Dr. Davis, it's a pleasure and honor to have you with us this morning on Kent's Kidney Stories.
It's an honor to be here. Thank you.
The above introduction was gleaned, I might add, entirely from the narrative within your research project. And this collaborative study is to look at lithium, as a treatment for bipolar, and it is very successful, but it comes with some profound risks for kidneys, and that's what we want to really delve into.
Sure.
So first of all, give me a little background about yourself personally, and we'll set this all up.
Sure. And maybe why I ended up writing this paper.
Exactly. That's exactly the purpose.
Yeah. So I guess the short story is I wanted to donate a kidney and I take lithium. The slightly longer version is that I was a non-directed liver donor in 2022 and had a very positive experience with that. And I knew that taking lithium would be a barrier to becoming a potential kidney donor. And so I kind of went back and forth for a while. Do I really want to try to do this? Do I want to try to overcome these hurdles? And then I decided, yes, I do. And I was initially turned down upon initial review because of the lithium. And I'll say I take a very low dose of lithium. And as a psychiatrist, I understand the risks of lithium. I have many patients on chronic lithium therapy, so I do know that the risks are real. However, I do know that the risks are also small, and especially with low dose and when someone remains in a certain therapeutic range. And so after I initially got declined, I for a while, I just kind of sat on it. It never feels good to get declined, especially if it's due to something you don't necessarily disagree with. And then I decided, well, one, if I'm going to do something that others perceive as potentially risky or maybe even foolish, I should really understand what I'm asking to do. And even though I understood it from a broader clinical perspective, I had never really completely delved into the literature. So I did that. And I found several other colleagues here at CU and Toots who were willing to write this paper with me, who kind of felt the same way I did. And we started writing this paper. In the meantime, I approached several other transplant centers and was declined again by several due to lithium. Eventually, one transplant center was willing to consider me despite the lithium, but ended up having concerns about kind of my post-surgical anatomy after the living donor, the liver donation. Yeah. And but ultimately, CU, where I work, was willing to reconsider me, even with the lithium. And I moved forward with the process, ended up having an excellent GFR over 100, which was good news. Wow. Yeah. But ultimately, they had the same concerns about the post-surgical anatomy and some adhesions I have, and that would make it too risky to donate a kidney. But in the process, I was able to write and publish this manuscript, which I'm, really happy about.
Oh, I loved it. I'm going to tell you something. I read it 3 times. And
yeah.
It stuck with me every time. And the biggest thing that stuck with me, 79% of these programs just don't even think about doing a donation from a person who's on lithium.
Right. Well, and then there's a question: what is an active mental health problem? Right? What does that? Yeah. What does that even mean?
Yeah. So explain the the dosages and what really gets people in trouble, because I've had 5 or 6 patients who have had lithium toxicity and it caused renal, dysfunction. And in some cases, it's caused total renal failure.
Sure. Well, I think there's several things worth looking at. So one is the risk of acute toxicity, which can cause renal failure. So if someone has a level higher than it should be, it can acutely damage the kidneys and lead to renal failure. And then there's the more kind of insidious long-term effects of chronic lithium. A lot of the literature that suggested or showed that lithium was associated with a significantly higher risk of end-stage renal disease was when people used lithium at much higher doses and higher serum levels. And so now, generally, we try to keep people around a level of 0.8 instead of, in the past, people used to maybe aim for 1.2. Now, I will say the literature doesn't fully support that it's dose-related, the risk of end-stage renal disease.
Okay.
But clinically, I would say it seems to, I mean, it may be, I guess, is what we can say with the literature.
Sure. And you've seen it, in your practice, right? You've seen
I have. Now, I have only seen it in one patient, and I think that's the important point is
Wow.
we're not saying there is no risk. There is a risk, and my point of the manuscript was that the risk from lithium is comparable to other risks that are considered acceptable in healthy living kidney donors, and that the risks can be assessed using the same tools that they use to assess other donors not taking lithium.
Right. And it seems, according to the manuscript, that it's there are really a lot of biases and it has to do with it, doing an interview and then you progress. Can you explain that a little bit?
Yeah, I mean, I think there's biases on several levels. I mean, I know that it's really probably only recently that people have started to recognize that maybe non-directed or altruistic donors are actually just as psychologically healthy as the general population, or
Yeah,
maybe
right.
even healthier. I think people used to have a lot of skepticism about people who would want to donate a kidney or part of their liver to a stranger.
Oh, it's still there. It is
Right.
still there.
It is
You
definitely
bet
still
it
there.
is. Yes.
And that's one reason at first I was even kind of hesitant to talk about my experience, because I didn't want people thinking I was just totally out there. But so I mean, so you've got that at baseline alone, and then you take someone with a history of a mental illness, and we know there's all sorts of stigma in our
Oh,
society
yeah.
about mental illness. And so there's the realistic concerns about lithium, and then there's also the bias towards people who have mental illness and whether or not they can safely move forward with living donation. I will say our program here at UC Health and CU Anschutz, I think is really progressive, and they do not automatically exclude people with mental illness. They do an assessment based on current risk factors, current functioning, support system. And when I filled out the initial application to donate my liver, I was like, they are not going to want to touch me with a 10-foot pole. I'm on lithium, I have mental health diagnoses. And so I followed up my application with an email to the transplant coordinator. I'm like, just a heads up, I know my medication list looks scary, but I function well. I'm a physician. I haven't had any hospitalizations. And they didn't turn me down. They took me seriously. They moved me forward, and I give them real kudos for that. I think they handled the process amazingly.
That was real interesting. That was going to be one of my questions. Did you have any grief when it came to being selected as a donor in the liver transplant? And evidently not.
I did not. They were very like I said, progressive and open-minded, and they were thoughtful. They asked really important questions. Like, they wanted to understand that I was currently stable and that I had a support system and that I was willing to do more therapy if needed, and that I understood that my mood could be exacerbated during the process. And so they were realistic.
So when you look back on that experience with the liver, it kind of it kind of got you going in the right direction. It was something that you really wanted to do, right? It was in your
Right.
heart.
Right.
And what was that possessed? What did you have that made you want to do that?
Um, I feel very fortunate that throughout my life, I have always had a sense of purpose and direction. I knew from the age of 3 that I wanted to be a doctor. Well, first I wanted to be a bird. My preschool teacher told me I could not be a bird, so I decided on doctor. So I always knew I wanted to go to medical school. Um, I think things just seemed to fall into place. And so my first year of medical school, I was in a lecture and they were talking about living liver donation. And I thought, you know what? I want to do that. That's something I need to do. At the time, 20 plus years ago, non-directed donation was not a thing. However, I reached out to the medical director of liver transplant, and he amazingly actually took me seriously and met with me. But he did the first thing he said is, "Well, we need to have you have a psychological evaluation." And I thought at that point I was 21. I thought, "Oh, they're going to think I'm crazy. I can't do this." And I didn't move forward. And anyway, I couldn't have done it as a medical student, but so it's always been on my mind since then. And fast forward 20 years, I was on the UC Health website. I came across an article about actually one of their double donors who had donated both liver and kidney, and there was a link to fill out the form, and I really just without even thinking filled out the form, and there we went.
So you did apply, right? And of course you were rejected. And was it just merely because of your lithium usage and
So
your
you mean for
diagnosis?
the kidney?
Mm-hmm.
Yeah, so they did review my application with the selection committee and then initially just declined me without moving me forward for further evaluation because of the lithium. And uh that was disappointing, but really not surprising. I mean, it's
Right.
basically what I expected.
Did you have a feeling? Of course you did when you were going to do this that was going to happen to you. And were you already thinking about, okay, I know what's going to happen. I'm going to start thinking about how we can, in retrospect, take a look at it and fix it because I really want to do it.
Not necessarily. It was more, well, maybe they'll listen to my reasoning. Maybe I can talk with them. You know, so I didn't really decide to kind of push it forward until after the fact. And again, I think some of that comes down to just this idea that people think it's a lot of people think it's kind of a weird thing to do. And here I am trying to argue with people to let me do something that a lot of people might think is foolish because they don't really understand the risks. Do I really want to put myself out there like that? And so that's why I sat on it for a month or two. And then I decided, yeah, I do want to put myself out there. This is kind of my MO. If there's something that I believe is not being done or being done for the wrong reason, I like to challenge it.
Well, it's evident in the writing, in the research, or in the manuscript that it was really it was really on your mind, and you looked at it from a clinical standpoint. It's very important to realize that people get rejected every day, and they don't get an explanation of the rejection. It's just a
Right.
general form letter. Patients don't get to sit on these boards, and that's neither here nor there for this conversation. But still, you didn't get many options. You didn't have many options. It was either yes or no.
Right. And I actually think the experience of being rejected, while it's disappointing, has been very beneficial because it, I think, gives me more empathy and understanding for what it must be like to be, for example, a family member who wants to donate to a family member and gets rejected. I mean, the disappointment that I felt was purely based on this is something I want to do because it's important to me, but there wasn't someone connected to me who was
Right.
depending on it. And so I can only, I can't really imagine what it must be like for a family member to go through that process and get rejected and not even really understand why necessarily.
We have yep. I think that's the most important vibe here is that for no reason in their
Right.
mind, if it's clearly stated because you do this, that, or the other, okay, then you can live with that. And maybe there's an adjustment that you can make to make it better. And then you can donate. But
Hmm.
in general, it's not very straightforward. I mean, the explanations may be vague in most cases, but It's tough to experience that. Really tough.
Well, and that was one of the things that probably really contributed to me deciding to move this forward is I recognize that I'm very privileged in that I am a medical professional, and that partly because of that, I think people will take me seriously, and I have the ability to write a clinical paper and,
That's
you know, we
evident.
did get it published. I also feel so I felt it was important that I use my privilege and my position to do something potentially useful, even if it couldn't necessarily help me move forward, might help others.
Okay, so you had a couple viewpoints in that, and I'll refresh you. Do you remember there were a couple specifically challenging? It was you called it carte blanche
Yeah.
exclusion. Explain that a little bit.
Well, I couldn't find any data per se about centers excluding based on lithium, but based on my experience of calling several centers and them automatically saying, no,
You-
sorry, because of the lithium. So carte blanche was my experience, except for the one center I found that didn't. Um, yeah, it's
Okay.
basically on lithium. Don't need any more details.
Yep. Don't need to talk about that.
Right.
Yeah. And then the second thing was the importance of best available data.
Right. And that's what I wanted to do is look at what data is actually out there and are we making decisions based on that data instead of, anecdotes or stigma.
There were a lot of references, and a couple of them I didn't didn't talk about who made these statements, but all the statements that I read were documented, footnoted. I
Correct.
think it's very, very interesting that a lot of these people said there's, you know what, if the management of the lithium is under control and the patient is adequately controlled on it, their lives are a whole lot different than if they weren't on it at all. Is that correct?
Correct. Absolutely.
Yeah. So I think then that's what they look like for in a psychiatric evaluation pre giving your kidney up is to take a look at can they handle that? And most people on that were on lithium, that how many do you figure that there would be that would want to donate? Was there anything on literature like that? How many had been rejected? Probably not.
There wasn't, no.
Yeah, that's the most difficult thing. People say, well, gee whiz, it's pretty rare that anybody that would want to do this, but still, if that's that's a donor. That's a donor that's not being going to be able to help somebody I get off the list or
Right.
whatever. So
Right.
yeah. Well, in your research as you're looking at all of this stuff, what stuck out to you the most? What was really evident that you really honed in on?
I mean, what it really came down to for me is looking at the other risks that are considered acceptable in living donors
Yeah.
and realizing that those risks are similar, if not greater, than the risks of being on lithium. For example, um, controlled hypertension. Some centers will accept donors, or even being male or being African American or Black increases your risk of end-stage renal disease. And there's even literature about the higher risk in, certain groups of people post donation with certain characteristics. The other thing that stood out to me is there was a paper by Hayes, his group, that they took 44 factors of people on lithium and they put it into this equation to determine risk of end-stage renal disease. And what they found is that 44 very specific 44 factor analysis was no better than the standard 3-factor analysis that is often used to pre- predict or potentially predict risk in the general population. And what that said to me is that there isn't anything specific to lithium that means we need to measure anything differently. We still need to look at, you know, I'm actually not remembering off the top of my head. I'm not a nephrologist what those 3 factors are, but if you look at the standard analyses, that captures what you need to know. So, for example, my baseline GFR after 10 plus years on lithium was excellent. So, considering me as an individual patient, one could reasonably probably say that if my GFR is over 100 after 10 plus years on lithium, I'm probably at reasonably similar risk to the general population.
Exactly. As you compared it to hypertension too.
Right.
Some programs just will not do that, even though you've been on it for a given amount of time, maybe 10, 15 years, and you're stable. I mean, they can do 24-hour blood pressure check on you, and still you're fine. Your blood pressure stay normal. So there is an indicator here.
Yeah.
Very interesting.
I think another important point it comes down to is patient autonomy and shared decision making. And, living donation is unique because we're asking a provider, a surgeon, to potentially do something that could be harmful to us, right?
Absolutely.
And we're asking them to let us have autonomy to make that decision. Um, the one thing I think of sometimes is, well, that happens all the time with cosmetic surgery, right? People
Yeah.
can want something that has absolutely no medical benefit, and they're asking a surgeon to take risks and do it. And I know it's not quite the same. I know the risks with living donation are usually greater than the risks of cosmetic surgery, but we as a society tend to accept cosmetic surgery, people asking for things that don't medically benefit them. And so why do we have often more of a paternalistic viewpoint when it comes to people wanting to be living donors? You don't want to let someone take unreasonable risks. You don't want to let someone do something reckless or dangerous or something that doesn't make sense. But I think there is room for helping someone understand what the risks really are and then letting them make an informed decision.
Isn't that what a patient's total objective is, if they're really thinking through the entire process, is give me options,
Right.
right?
Yes.
Don't tell me what to do or
Right.
recommend what I do. Just give me my options, and then I can make a decision. But I'm doing that under medical supervision anyway. So,
Right.
instead of worrying about, well, this might hurt them or whatever, at least give them the option. And that's what we say in the kidney community all the time. Where are my options when you have a problem with the transplant program? What are my options? And they usually come around at that point in time. And very
Right.
important aspect for patients to realize is they have to have options. You can't make a
Right.
decision without good options.
Absolutely. And I'll say, even though I initially did not agree with my reason for being declined, I felt that ultimately the reason that they did decline me because of my post-surgical anatomy did make sense. And
Well,
actually,
sure.
one of the surgeons was very gracious, and she sat down with me and she went through my CT scan, and she pointed out exactly what was what the concerns were, and I could see it. And I felt that was shared decision making. She said,
That's
these are the
right.
concerns. It made sense to me. I thought, okay, I don't want to do something reckless. I do value my health, and I appreciated her walking me through the facts.
One good thing about, I'm going to say this in general. I can't quote you any statistics, but the vast majority of transplant programs have the donor in mind. If
Hmm.
you realize, and the surgeon for sure has got the donor in mind,
Right.
they do not want to put the donor in jeopardy. And if it's going to trip them up later on down the road, and they have a clinical process that proves that, they're sure going to go ahead and say, no, here's the reason.
Right.
But it's nice to get an explanation.
Exactly.
So I've thought about this a lot with lithium. I just wanted to kind of go back to it. If the doses, over a long period of time, do they fluctuate, or are you pretty well on it like we are with immunosuppressives? After it's stable, we stay on the same dose the whole time. Is that pretty much the way it is
So that's
clinically?
a very interesting question. So sometimes yes, sometimes no. So um, one of the reasons a dose may change actually is because if someone does develop end-stage renal disease or chronic kidney disease, they won't excrete the lithium as well, and so they'll actually need lower doses over time. And so sometimes the literature is actually confusing because when you look at it, it may look like lower doses are associated with end-stage renal disease. There's a few studies out there that look like that, but the reason is that someone actually has the chronic kidney disease, which leads their dose to being lowered because it needs to be lower to maintain the same serum level. Does that make sense?
Yes, it does. It
Yeah.
does a lot, because critically, most time you get, you just stay on the same dose, even though you have symptoms, and having lab work come back that shows you have some renal impairment ought to give you pause real quick.
Yeah, and that's the so lithium has a very what we call narrow therapeutic index, which means there's a very narrow range in which it's effective. Now, I take a very low dose because I take it for depression, and lower doses are effective for depression versus if you're taking it for mood stabilization in bipolar disorder, you usually want it to be around that 0.8 level, and there's not a lot of room for like going much higher or going much lower. And so most people will find that level. And as long as their renal function stays good and they're
And
not
that's
on
good.
any other medications that interact, then yeah, I'd say generally people would stay on a similar level.
Okay, so lithium in itself, it's out there in the environment. It's
Mhm.
something that we consume all the time, and we don't
Yep.
even realize it. Is that, you know much about that?
Well, did you know they actually used to have lithium in 7 Up? That's why it's called 7 Up because it elevated the mood because of lithium.
Is that right? I didn't
Uh-huh.
know that.
Yeah.
Yeah, so that into my mind is important, because people think on the same line with prednisone, for instance. If you take that for a long period of time, go off of it, you can have great difficulties, but still your body manufactures it.
Right.
So the body's a wonderful thing, and when you have something that's in the environment and it's known to be effective for greater than 60 years,
Mhm.
is there still taboo within the community about being on it?
Yeah,
Okay.
absolutely. There is. I mean, even with my patients, I know lithium works very well for depression and very well for mood stabilization. But often, the minute I mention lithium, people are like, oh, no, I don't want to be someone on lithium. I mean, it still has a very bad rap, unfortunately.
Yeah, and that's significant to me, because I see that in a lot of the patients. Oh, I wish I'd never been on it. Well, I understand that, but it helped you, right? And going off of it, some people go off and come back on.
Yeah, and I think the other one other thing to highlight is that we do know that actually the risk of end-stage renal disease in people with bipolar disorder is higher than the general population, regardless of whether they're on lithium. And so, some people who were on lithium and ended up with end-stage kidney disease may or may not have been related to the lithium. It may have been related to mood stabilizers. There was one study I referenced in here where people actually on non-lithium anti-epileptic mood stabilizers had a higher risk of end-stage kidney disease. And we also know that, chronic mental illness is associated with metabolic syndrome, hypertension, diabetes, all these things that are also associated with end-stage kidney disease. And so often it probably wasn't just the lithium alone, it was probably all these risks that, people with mental illness are at higher risk for.
I think that's significant, because people who are listening to this, and maybe there's some, when they see that in the introduction, that lithium it's a very fine drug if it's well utilized in the medical community, but it carries this stigma just like mental illness does.
Hmm.
That but if it works, my goodness, and it's monitored, that's important. So going to your physician. I think it's getting a bad rap, and I wish there was a way that we could fix that.
Well,
It
and
changed
that's
my
one.
mind.
Well, and I'm gonna say that's one reason I'm willing to speak about this because I am a physician. I function well and I take lithium and people may judge me for that, but I also hope people will see that and realize that taking lithium doesn't mean you're a non-functional, severely mentally ill person. You can
It
take lithium and it can help you be the functional person that you want to be.
Well, this is the problem with podcasts. Sometimes you can't see. You can't. I'm looking you directly in the face, and I'm telling you what. I think it's a really. It's changed my opinion considerably because I was thinking, well, why did they adjust this person's dose, or what was
Yeah.
it that caused them to go? And it couldn't even be from the lithium, like you
Right.
said, might not even be from the lithium.
Right.
But it's constant monitoring, and I think that's all we really need to be telling people is you can't just go on something and then not get monitored. If you want to get on something, no matter what kind of drug, you got to have it monitored. You got to know what your lab work is. You have to know your numbers, and then you have to know your symptoms. And there are symptoms, I'm sure, with toxicity.
Yes.
And could you explain some of those? What kind of things occur if you're getting too much?
Sure. So, you get ataxic, which means you can have trouble with your balance and trouble walking. People start getting slurred speech. They start getting confused. Tremor is a common side effect of lithium, but if you get a severe tremor, that can be a sign of toxicity. Being very sleepy. Um, I'd say those were the main ones. Just
Yeah,
being very
sure.
sleepy, confused, out of it, and troubles with balance and coordination.
Yeah, it's like a sensorium thing, right?
Yeah.
Yeah. So I really think that I would like to really know what your feelings are about getting this word out. I'm really interested in seeing you do that. Are you reaching out now in the medical community and just in general?
Well, I don't, not necessarily. I don't know who exactly to reach out. I mean, I would love to get the word out there. Um, and the most important message I want to convey is I'm not saying lithium is safe and doesn't cause kidney
Oh, no.
problems. Like that
No,
would be
no, no.
stupid. We know it does. But
Exactly.
I'm saying you need to consider each individual patient and their health and their context, and that the risk of lithium is similar to the other risks that we consider acceptable when we individually consider potential donors.
And I think that's the takeaway on this whole project, this whole
Yeah.
research project, and it's well borne out. And this is now published.
It is. It is online, and it's open access, so anybody can access it. It will be in print actually next month in the American Journal of Transplantation.
American Journal of Transplantation. That's great. Make sure you get back with me and I guess I can look the link up. I don't need to be
I can
lazy.
send it to you. Again, it is live, so I'll send it to you.
Okay. Okay, that's you know, I think we put a really a good shellac into this subject.
Uh-huh.
It taught me an awful lot, and I would when this article comes out, whoever's listening, I would encourage you. It's not an article; it's actually a project. It's a research project, and it's well done. And I think you would it would behoove you to go ahead and check it out. And when that comes out, we'll put it out on Kidney Solutions, and we'll also send it out to our email groups and definitely going to send it around to all of my friends because I know that a couple of them are on lithium. Right.
Well,
So,
thank you. I appreciate the opportunity to talk about this.
yeah. So I'm going to just let everybody know that it's going to be available. And at some point in time, I'd really like you to consider coming on our support group. We have about 30 to 40 people on a support group that would just give some exposure. And I'm sure that there are some in there quietly that are on it, or maybe not, but at least we would get another opportunity for you to talk, give a
Sure.
short presentation, and then we have questions and answers. I think it'd be fantastic talk. I've
Yeah,
just
I'd be
really
happy to.
enjoyed this. Okay.
Happy
All
to.
right. And the second thing that the Kidney Solution want to make sure you realize is that James Myers is a very good friend of mine, has a Friday night show, and I'm going to encourage him to contact you and ask if you'll come on his show. It's a live broadcast on Friday nights
Okay.
and talk about this. And I think that would give you, he's got fantastic exposure.
Okay. Great.
So at least that will be a kickstart. And then if there's anything, really honestly, anything that Kidney Solutions can do for you as far as getting the word out, we'll be more than happy to do that.
Great. Well, thank you. I really appreciate it.
Okay. And I'm sure glad we got to meet.
Yeah, likewise. It was a pleasure talking with you.
All right. All right, folks, listen, I just wanted to pass along that we were the fortunate recipient of an award of $20,000 grant from James Avery Craftsman in Kerrville, Texas. I wanted to do a shout out to James Avery, and the group out at here in Kerrville, Texas. They're a silversmith company of over $500 million. They spend a lot of time giving back to the community, and we were the grateful recipient of the wonderful donation. And we've also wanted to thank Bobby Reed. I know she's going to be listening, for the donation from the golf tournament that her son had, who's looking for a kidney, also a kidney donor, and that was in the form of $2,200. So we're doing very well, and as you know, this is organization Kidney Solutions has no salaries, has no benefits. Everything that we do here is done free of charge. No one has a salary. And all the money that comes in goes to directly to assist the patients in some way, shape, or form. And so think about donating. That's one thing. But I want you to think about the many people right now that are suffering out there. This kidney disease it's not fun. No one believes it is, but it puts the people in a position where they have a hard time telling you because they don't look bad. All right. Very few people know by looking at someone that they have kidney disease, even when they're in renal failure. So bear in mind, when you see have a chance to consider donation. If you had not just on your driver's license, but if you want to do a living donation, we have many qualified individuals who tell you about the experience. All right. And we look forward to helping you and giving you the information you need to do that. So living donation, as long as you're healthy, remember, the risk to you is mitigated by the fact that the health and the medical community is not going to put you at risk. It just will not do that. And that's borne out in this research project that's done too. Anyway, long story short, we're looking for donors. We need donors. The waiting list is long and the number of donations is small. So let's give it a shot. Think about it, pray about it, and give us a call at Kidney Solutions, 830-285-2140. And until the next time, keep breathing.